From the plains to the rolling hills, Oklahoma is a state that resonates with stories of resilience, determination, and pride. Welcome to Inside the 1581, a podcast of the Oklahoma Hospital Association. Together, we'll dive deep into the heartbeat of the great state of Oklahoma as we journey through the rich history, diverse culture, and the ever-evolving landscape within the 1,581 miles of border in our nation's 20th largest state. Each episode of Inside the 1581 will feature conversations with the many voices which help shape our state's future and our shared vision of improving health and healthcare in Oklahoma.
All right, thank you for joining us here Inside the 1581, and thank you for our sponsors at PYA. I'm joined here with Chris Wright, who's the CEO at Purcell Municipal Hospital, and Dr. Matt Jarrett, who is a telehospitalist at Purcell Municipal Hospital with the SSM system and works at a number of our hospitals across the state. And so, gentlemen, we were talking about denials when we took our break, and I went back to our survey, our public opinion survey, pulled up another question that we had asked, and the question was, the results of what we learned is that more than a third of the respondents have been denied care by insurance, and about 4 in 10 have found their care delayed. Mm-hmm. And so when we drilled down to the question, we asked this: have you or a family member ever been denied medical care or testing by an insurance company? And 35% said yes. 50% said no. And 16% said, maybe, not sure. So clearly, more than a third have indicated that they have. And then we asked the question, have you or a family member ever had medical care or testing delayed by an insurance company? There the number goes up. 45% said yes, and another 13% said unsure. So again, almost half of the respondents have indicated. So clearly there is a sensitivity to care being denied and care being delayed. And we were just getting into that, some of those examples. And so, Matt, you gave the one story, but you also gave me a little one in break about some systemic behaviors. Why don't you talk a little bit about that?
Yeah, let me kind of tell you guys the issue that we run into with this, and it's so fascinating to me how automation and AI may play a role in it, but you talk with these providers on the other end of some sort that are doing the peer-to-peers with us when we finally get to that point. And, you kind of can get some questions asked and answered, but had a patient that came in with heart failure, very swollen, not breathing well, had fluid trapped in their lungs, obviously, very ill. They needed oxygen to even just survive and breathe at that point. And we go to take care of him. We met him at the hospital, gets denied. The insurance company says, no, you can't admit that. That's not sick enough for the hospital. Oh, okay. It always has been. That's strange. So I go to
probably was under traditional Medicare. Probably wouldn't have been a problem.
Well, no, it wouldn't have. This would definitely not have happened under traditional Medicare. But it is a Medicare Advantage plan, is one we've referenced. And, it's one of those things that you have to call them. You have to take care of it. You have to go through the slog of all the hoops to jump through. So I get on the phone with this physician to do the peer-to-peer and talk with him. He listens to what I have to say. He said, well, yeah, sure, that meets all the guidelines. We'll get you approved, no problem. And I said, it's strange because I knew this was an inpatient from the get-go. It meets all your criteria, and you actually have access to our EHR to review our records, and yet you denied us. And he said, well, we don't approve any of these until they've stayed 72 hours. And I said, well, that's interesting. Well, but we got the denial right after the second day. He said, well, we also want to make sure everyone knows where they stand, so we send out all of our authorizations within 48 hours. I said, well, if you can't approve it until 72 hours, then you deny every heart failure admission that comes in the hospital now. He kind of paused and you have to wait till 72 hours. And I said, so you deny every single one systemically? And he didn't want to admit it, but tacitly did admit that, yes, they deny every single admission for heart failure to the hospital. And then subsequently, if you jump through the hoops, they'll approve it after 72 hours, which is just both fascinating and just obscene at the same time, that you're going to put patients and hospitals through this for no recourse whatsoever to your own company, other than this guy's actually having to be paid by the company to do this, and they're going to approve it. It seems just ridiculous to me.
So you're in that scenario, And so you've got this patient that you know needs to stay. With all of this, negotiation in some respects, and we'll talk about negotiation of cost, because I know, Chris, you gave me an example on that, but you're negotiating literally the life of this patient.
Yeah.
What are you saying to the patient? Do you just not disclose this to them, that you're trying to be, to negotiate on their behalf? What do you say to the patient, and how is that received in light of what I just shared, the public sentiments towards denials and delays?
Yeah. I was actually thinking about this when you're talking about that data, because I think the data is actually wrong. I think
it's higher.
Much higher.
Yeah.
His experience to delay or denial. They didn't know about it, because you're right. I don't tell the patient. I know that ultimately I'm going to jump through all the hoops and make sure they're taken care of. And as a hospital, we're not going to turn them out and say, well, your wallet biopsy didn't work. You're going home. No, we're going to take care of the patient, because that's our responsibility, and that's our calling in life. That's our oath and our promise. And so no matter what happens, this patient's going to get care. It's just a matter of how hard is it going to be for us to get reimbursed by the plan that says they're going to cover this patient's care for the care that we've delivered. And that's ultimately where the problem comes. The patient doesn't need to know about this. Now, at some point when it comes down to discharging or making a plan in a timely fashion, and we're running into roadblocks where they're doing well, they're getting better, but we don't know anything yet, then we have to let them know. But until then, I don't need to overburden them with that information. I'm going to take care of it. It's my burden. That's my job, and I'm going to take care of it without letting them know until they need to know, because ultimately I don't think it will affect them. If it is, then I'm going to step up and let them know, hey, looks like this is going to get denied. This is where we're at. This is what's happening. This is how I'm trying to fix it for you, and this is what the hospital's doing to work with us to make sure that it's taken care of. But we want to give you a heads up that this is not going the way we thought it would. At that point, you let the patient know.
Well, and I think you said it. I mean, our promise, to the patient, to their families, we're going to take care of you. Mm-hmm. And so, and I think that is in part of what the health plans, build into their business strategy. Yeah. That once the hospital has them, well, hey, they're going to deliver everything that's necessary to heal that patient, and we can probably squeeze a little bit more juice out of the hospitals during that process. Yeah. And I think some of that does take place.
Well, and think about what delay really means. We're not talking about you didn't get your food for 2 more minutes, and so you may be real hungry. These are people who are sick. They're suffering. Right. This is not a plastic surgery. They're not waiting for delayed eyebrow lifts.
And the most frail population typically, too.
They're waiting because they're suffering. They need care. They've already been told by the doctor that it's appropriate and that it's necessary. They've presented with these symptoms, but we're delaying that relief of symptom. We're increasing their suffering. That's what delay really means. And it gets, I think, given an improper word with delay. It's really suffering that's ongoing that insurance companies just let happen a little bit longer. Just how long can we let them suffer before they really throw up their hands and cry havoc?
Well, and then we just talked about that, because ultimately they do approve it, and ultimately, with only a total denial of 2.3%, they're moving forward with it. So it really is a good illustration, what you laid out there. If we talked a little bit about, we've just now talked about denials and delays and things like that, but we do know that seniors have questions. And they're asking questions. Well, do I stick with traditional Medicare? Do I move to a Medicare Advantage plan? Between the two of you, what do you think are some of the questions that they should be asking about whether or not Medicare Advantage makes sense for them? So I'll start with you, Chris. What are some things that you would think that seniors need to be asking as they're making that determination for themselves?
Well, I'm part of Rotary, and I get to see a lot of seniors in our Rotary Club, and I get approached frequently about, whenever they get, I just turned 65, I get onto the website. First thing that comes up is Medicare Advantage commercials, basically pushing it on them where you're
I'm
registered.
Only 60, and I'm getting them, so they're investing early in life.
So they think, well, this is Medicare. In their minds, they don't understand the difference that it's contracted, and that's why I am so thankful that the OHA has put together this disadvantage website to give them more facts and information, and that's what we're trying to instill them with, and how we can educate ourselves. Because if you're healthy, just like your mother, for all those years, that's a great plan. It's whenever you finally have to utilize it, and on the back end, if you need those additional services, where you suffer. And we'd really like for the community and people to know more about what goes inside this and the risk that you take if you do sign up for it. And it's not always easy to, if you enroll in it, to transfer back over. I mean, you have to wait and stuff. The fact that in 2025, it's projected that 51% of all Medicare recipients will be in Medicare Advantage, and so it's continuing to grow. And I'm concerned about that because people that travel and go in different places, if you're isolated, to just these rural areas and stuff, you don't get to take full advantage of what they have to offer. And in turn, I think that the patients that have to come in and receive the care, sometimes we can make them even more sick because we're not able to rehab them in the appropriate ways that can optimize their outcomes.
Well, I think that's a really good point. I mean, as I step back, working with my brother and sister for my mom's care, some of the key questions we asked when we were initially moved her into a Medicare Advantage plan a number of years ago when the program first came out, obviously is her physician in network. So you're sitting there, you're comparing all the plans. Is the hospital that she would in all likelihood use, is it in network? Oh, not in this network. They are in that one. Okay, so now we've narrowed it down. What is the skilled nursing benefit in this? Because some don't have any, or it's very slim. For my mom, was she going to use a health club? No. But did it matter? But we Googled anyway. We'd say, are there any in the community? No, there were none, in the community. Mm-hmm. So that benefit that is oftentimes being promoted didn't even exist. Her optometrist wasn't in the plan, and dental wasn't in the community. Now, it is in the greater metropolitan area, but not where my mom lives in that part of Central Florida. So it seems to me that for seniors, there's a little bit of work that you have to do, and there are some resources that can help seniors. And so if you go to our website, MedicareDisadvantage.org, there is a resources page, and there is a couple clicks that seniors can use to get some outside resources. But it would seem to me that those are some basic questions. So, Matt, in your experience, you're talking to patients, and certainly you're practicing in a couple different hospitals. Are there any other questions that seniors should be asking themselves when they're evaluating? Is this the best coverage option for me?
Well, I think ultimately insurance is a financial agent, right? And so what are your finances going to allow for? That's an answer you have to
Good
answer,
point.
right?
Yeah.
If you can't afford food because you're paying too much for your premium, that's a problem. But you're right. You get into these options, or maybe there's capped costs, which is something that some people may need if they're a heavy utilizer. But, maybe they can't get the dental. I would always talk to patients and I say, look at those options, though. For a 65-year-old, really healthy person, it sounds like your mom probably was,
right.
Having dental coverage, if it's available, may be a nice benefit to have without any extra cost. And so there are some things that you may want to consider that would cause you to think, okay, a Medicare Advantage plan is. But I think of it very similar, just in broad strokes. If you're 21, young and healthy, how much insurance do you really need for your health? Well, you want some. Anything can happen. But
you want to cover the catastrophic event, certainly.
You may not need the massive skilled nursing benefit at 21. Likewise, when you're 65, if you're young, healthy, you haven't really had health issues, you may be able to get away with saving some money on your premium with a Medicare Advantage plan early on. But as you age and as you see, hey, I've got a couple of medicine, new prescriptions in the medicine cabinet now. I've got a procedure I've got to go do for my knee now. Some things coming up. You have to start thinking to yourself, what's really the benefit to saving money on my premium if I'm having to spend extra money at the end of the day to get all these services that I'm actually going to need? And so there is a transition process you have to think about, and I'm glad you mentioned the resources. The state has a a free resource that you can call into and get unbiased help without talking to one of these Medicare Advantage plans directly to help you make a choice if you need to. But there are reasons to choose a Medicare Advantage plan, but you have to be cautious because they make it sound like it's the greatest, best thing ever, just like any commercial for that big new toy or that great new car. They're going to tell you it's the best and you can't live without it, but what you really have to find out is it what I need? And is it what I can afford? And how's it going to benefit me in the long run? Because most people are on a fixed income at that point in life, and you need to think about your finances when you're making these decisions.
Well, and oftentimes we're being sold, oh, it's free. You're still having the cost of the health plan taken out of your out of your Social Security, right? So it's not free, and the difficulty I think seniors are faced with is that you have sales reps that are paid on average $600 per Medicare patient they sign up. So they're highly incentivized to sell this, and you're a senior in your 70s or 80s, and you've got a fast talking salesperson on there. If you don't take time to say, I need to chat with my son or my daughter about this before I make a decision, or my spouse about this, you could find yourself waving away a lot, just as you just referenced, Matt.
I have an actual example of that.
Okay.
As we talk about these examples, I have a patient that I see in clinic, and one year she got switched to a totally different Medicare Advantage plan, just out of the blue. She didn't even know it had happened, honestly. And when we researched it, we found out someone had called her phone and said, hey, I'd like to talk to you today about how I'm going to be able to switch you to a better Medicare Advantage plan. Is it okay if we talk about that and have that conversation? And she said yes. And he used that as tacit authority to go ahead and switch her because he'd said, I'm going to talk to you about how I'm going to switch you today.
Yeah.
And so he switched her while they're on the phone, just talking about if she wanted to do it. In her mind, she hears, I'm talking about if this is a better plan for me than what I have. In his mind, he's explaining the differences, and he's already put in the paperwork and has signed her over to a new health plan that I actually wasn't on. And so for a year, I could not be her doctor without no charging her, which, of course, now that's inducement, and that's illegal too. We can get a whole other topic there. But, it's a total mess when you get on the phone with these guys, and sometimes they're going to prey on the elderly. They're going to prey on those who maybe can't hear as well, maybe don't have the nice new device that broadcasts the tone as well. And then, sure enough, you've lost out, you're in a hole, and you don't have the opportunity to get the care you need.
Well, in that situation, personal experience with my 95-year-old mom, we ended up by changing out and swapping out her telephone number. Mm-hmm. So we went to an unlisted number. We don't publish it anywhere. Yeah. So the only individuals that have that number are family members. Now, certainly there's probably ways in which they can buy numbers, but that significantly reduced any of those calls coming in. And during this time, during open enrollment, as I talked to family members that are 65 and are looking at this, their phone is ringing off the hook with solicitations for that.
Exactly.
And so you had mentioned a number, Matt. I think it's the Oklahoma Senior Health Insurance Counseling Program. And so for our listeners, it's a really good program that it's listed on our resources page for Medicare Disadvantaged. And if you get a chance to share that, I would encourage you. It's 1-800-763-2828. And it does provide those free resources to help seniors navigate through this. Before we close out, Chris, we talked just a little bit about the finances. And I know I've had a couple of CFOs who have called me and have said, Rich, my problem is I'm not in this Medicare Advantage contract. And so the plan should pay me my Medicare rates, but I'm not getting paid that. When I was in a Medicare Advantage, I wasn't even being paid my contracted rate. So it seems to me that what we have is a situation where there may be not enough regulation to ensure that the rules are really being, adhered to. And so at Purcell, if you experience that same, I think you're in all of the health plans right now. So you're still trying to ensure that you get paid what's in your contract.
Correct. And then you go through all the denials, and it comes to points where, you're basically negotiating services. We don't cover that, so we're going to dismiss this. So, like we may get, for example, a $1,500 reimbursement, and it comes down to we actually get $500 in the end. And
so not even paying what's in the contract.
Right.
So they're going to continue to put pressure on you to take further reductions off of what you had already signed a contract with the plan for.
Correct.
And so in that situation, that gets back to that question for you in ensuring your financial sustainability in the city of Purcell. You know that round numbers, you can correct me if I'm wrong, let's say 50% of your patients are Medicare, and of, let's say, 60% of that 50% are in Advantage plans. You're being placed in a situation where you're losing money on that book of your Medicare patients. If that represents a significant percentage of your overall patients, there's no way you can get above that, because you also have to be competitive in what you're being able to deliver for private health insurance.
Correct. And in the end, how much time do we have to go fight this?
Okay.
Do we take the money now and it's sort of guaranteed money, or do we risk not getting paid at all?
And that's probably built into the business plan of the health plan. So it's like, eventually we'll string them up long enough, they'll just accept what our last offer is. And really, we should be following what our contracts say,
That's exactly right. It's so sad, but it is exactly right.
Well, I think as we wrap this up, I think what's important, if folks that listen to it, is that if you are of that age, take the time to look at what the offerings are under original Medicare, what you can get under an Advantage plan, and particularly looking at hospital-sponsored Advantage plans, which really does bring those resources and concentrates in those community with a Main Street focus, because that's where they live, that's where they work. Everyone's connected, and that case management is much tighter than a health insurance sponsored plan. And making sure that if you have questions, ask your physician, ask your nurse practitioner, ask somebody else that you know that trust that can look over what the program options are for you. And I would encourage folks, too, to think about what does it mean to my local community. So if I'm signing up for a plan that my local hospital or my physician isn't even in, and I have to drive, not driving for Purcell, but imagine if I'm driving from Shattuck all the way into Oklahoma City to get my care. What does that mean? So you're taking care out of supporting the local community in Shattuck. Great, you're bringing it there, but you're also being disadvantaged by having to drive and putting your healthcare at risk for that care outside of your community. And so I think there's a lot for us to learn, and hopefully as folks make decisions, they'll be mindful of this. And Chris, Matt, thanks for letting us kind of promo the SHIP program, because I think that's a good resource for seniors. Anything else you guys want to add before we wrap up this edition of Inside the 1581?
No, I think this is a long conversation you could do several podcasts on. So I think it's a great topic to start the conversation with this time of year especially. I appreciate you letting us come by and talk with you. And we were talking about this because I've got to look up your podcast now, but it's the 1581 podcast. Remind me, how does that come up?
Great question. So we were trying to figure out ways to tell stories. And if you met my mom at 95, my wife will tell you she is a storyteller. And so we're trying to figure out a way to do that. And so we thought, well, let's do a podcast. People drive long distances, they listen to podcasts. So we're trying to figure out something that could allow us to tell stories. So here we're telling a story, your experiences, Matt, your experiences, Chris, on this. And so then what do you call it? And we were just sitting around just kind of noodling here, and it just occurred to us, well, how big is the state of Oklahoma? Well, it's 1,598 miles around the circumference of the state. So 5,881 miles. So inside the 1581. And so that's how we came up with the name. That's awesome. So we've done a few of these now. And our first one, incidentally, we focused in on the NBA season when COVID ended the NBA. And so one of our guests was the team physician for the Thunder. And we went through everything that transpired and behind the scenes, what was going on with the NBA, what was going on as they were trying to identify and test. We only had a few tests in the state at that time. Right. And so that was one example. We've talked about human trafficking. We've talked about workforce. And today, certainly, we're talking about Medicare Advantage. And we hope on our next episode, talking to some patients. So as you guys go back and you think of patients that have had experiences, I think we can learn from patient experiences from the patient as opposed to from our physicians, our nurse practitioners, or the hospital leadership. So
Great.
We'd welcome any suggestions. And so again, as we wrap up, I just want to say thank you to both of you for joining us this edition of Inside the 1581. Thanks for the question of why we named it. I hope folks are enjoyed this episode. And so before you go, I want to continue to extend a thank you to our friends at PYA. PYA is a national accounting, advisory, and consulting firm that supports hospitals and has been a strong supporter here of the OHA. Also want to thank our producer, Alex Taylor. Alex is going to be graduating here in December, and we're excited to bring him on full-time with us here at OHA. He produces our podcast, and our Director of Communications, Susie Wallace, who oversees all of this and keeps us moving in the right direction. Please make sure that you subscribe and follow us and stay up to date on future episodes. You can do that through Spotify or through Apple Podcasts. You just click it and it'll remind you when our new episode drops. And I also want to thank and continue to mention that our music that we use in our track is Gunslinger by Ends of the Earth, and we appreciate the use of their music. So until we come back again next time inside the 1581, we thank you for joining us, and we look forward to another conversation of what we are doing inside the 1,581 miles of the state of Oklahoma. Thank you very much.